My name's Sejal. Nice to meet you guys. I'm a second year med student. And today we're going to have Dr. Desai talking to us today about perioperative management of arrhythmias. So Dr. Desai did his DR residency at Brigham and then went on to do his IR residency at University of Virginia. And now he's back at Brigham and he did an IR fellowship in anesthesia and surgery critical care. And so he is now practicing in both IR and critical care, and a lot of his practice centers on vascular disease. And so we're really excited to have you here, Dr. Desai, and I'll let you go ahead and get started.
Thanks, Sejal, and thanks, Austin, and thanks to the whole WCVIS, particularly Dr. V for having me. I'm really excited to kick off this series. Thanks for that great introduction. Yeah, basically, my career, I was the first person to ever undergo a surgical critical care fellowship coming out of IR. And while that might seem kind of unique and out of left field, I think if you've heard Dr. V give any talks at all, you know that acute care and patient care is such an important part of IR practice, and it really should be taught in IR training. It's something that we don't do a great job of right now, but hopefully it's something that we will begin to integrate in large amounts in the future. So thanks to everyone who's joining in person and also everyone who's watching this recorded. I'm just going to get started here by sharing my screen. All right. Perfect. So today I'm going to be talking about the management of acute tachyarrhythmias for VIRs. The first question you got to ask yourself is, why should I care about cardiac arrhythmias, right? We could all, and at some point in our evolutionary ancestry, we were all like this poor orthopod, auscultating ANSEF pumps and not really caring about, the physiologic status of our patient. So that's kind of the fundamental question. Why should I care about the management of arrhythmias? Well, the answer goes all the way back to 1968. Charles Daughter, who is the founder of our field, had this very famous quote. If you guys haven't heard of it already, you're going to hear it many times through your IR career. So he said, if my fellow angiographers prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on transluminal angioplasty, so he actually invented angioplasty, they will become high-priced plumbers facing forfeiture of territorial rights based solely on imaging equipment others can obtain and skill others can learn. So basically what he's saying is, if we don't take on the responsibilities of non-procedural patient care on our own, other people will learn how to do the procedures and we will have nothing left to do. And it's kind of funny. I mean, today we're talking about, management of arrhythmias, management of cardiac issues. I mean, this is Charles Daughter himself doing coronary angiograms. Now, of course, we don't do those anymore. And largely that's because we gave up management, non-procedural management of cardiac issues, right? We said it's too much for us. And therefore, the cardiologist said, well, great, if it's too much for you, then we're going to do the procedures also. And so that's what we're here to change. So in 2014, for those of you that are kind of just getting into this field, this is really important for you, right? In 2014, the ABR created the IRDR certificate and the IR residency. This is brand new. And particularly, John Kaufman, who was one of the drivers of this, he said the major driver of this change, of this new residency, has been the importance of non-procedural patient care in IR and the need to provide this additional training. Before, all IRs were just diagnostic radiologists who like to do things with their hands, right? But now we got to incorporate these elements of patient care into our training as well. So what is patient care, right? What is non-procedural patient care? To me, there's two elements to it. There's acute inpatient and peri-procedural management, and then there's longitudinal disease management. So, for example, when you hear Dr. V give talks about the medical management of PAD, or someone talks about, the different algorithms for treating liver cancer, right? They're not talking about how to do these procedures. They're talking about the global longitudinal management of these patients. So very similarly, I think there's a real kind of vacuum or opportunity, I should say, in IR for increasing our knowledge base in acute, inpatient, and periprocedural care. Those two together, to me, form non-procedural patient care. So what is acute care? Well, it's kind of broken down further into these three things: inpatient admission and management, inpatient consultation, and then management of periprocedural emergencies. And the same knowledge base basically goes towards expertise in all three of these fields. So, when you're an expert in acute patient care, what should you be able to manage? Well, to me, you should really know shock, respiratory failure, all of these things, arrhythmias, which we're talking about today. All of these things, by the way, are in the curriculum for general surgery. They're on the general surgery in training exam, and also their boards. Every surgeon knows how to manage all of these disease states because they encounter them. They don't just do the surgeries, but they treat these kind of disease states. And I think as an IR in the modern age, this is way, right in our wheelhouse. So let's get started on today's topic. So you have a 66-year-old male, history of hypertension, diabetes, ESRD on HD. They've got a brachiocephalic AV fistula, and they're presenting because the fistula is clotted, and they're here for a thrombectomy. So the patient's here in our pre-op bay, and the nurse, runs into your room. And by the way, this is something that's definitely happened to me. The nurse runs into your room and says, "Hey, this patient has really fast rhythm on telemetry. What are you going to do?" Okay. So, here's my algorithm. My first stop in anyone with a rhythm disturbance, you have to ask these two questions. Number one, is the patient conscious? And number two, do they have a pulse? Right. So if neither of these are true, meaning if the answer to either of these is no, then you're immediately moving to your ACLS cardiac arrest algorithm. And that's not one that I'm going to talk about because, when you take your ACLS training, that's something that you get, well trained in. And so really useful to review those algorithms really well. But really today, what I'm going to be talking about is the conscious patient who does have a pulse, but has a rhythm disturbance, has an arrhythmia. Okay. So, you've determined that this patient has a pulse, and these are really the questions that you're going to start out with. Is number one, is the rhythm fast or slow? Is the patient symptomatic? Are there signs of hemodynamic instability or myocardial ischemia, meaning hypotension, hypoxemia, ischemic EKG changes? And are there symptoms of end organ hypoperfusion? So chest pain, dyspnea, are they altered? Are they lightheaded, dizzy? And then you start thinking about, why is the acute arrhythmia occurring, right? So, the minute the nurse runs in and asks you or tells you, hey, this rhythm is funny, these are the things that in your head you're already working on finding the answer to. That last one, why is the acute arrhythmia occurring? So these are reversible etiologies, and all of these etiologies are, again, something you have to keep in your mind anytime someone has a funny rhythm. So things like metabolic abnormalities, hypoxemia, hypercapnia, volume changes, acidemia, potassium and magnesium derangements, anything going on with the heart, literally anything, right? Pericardial tamponade, effusion, coronary ischemia, valvular disease, the list goes on. Obstructive shock, right? So things that are preventing the heart from providing adequate blood flow, things like tamponade, pulmonary embolism, tension pneumothorax, medications, intoxications, and then kind of the weird things like thyroid dysregulation, so thyroid storm, hypothermia. If you notice this list, for those of you who've done ACLS training, people always talk about the H's and T's. I always find that a little bit simplistic, right? Because the H's and T's, that's an easy way to remember things, but these are the H's and T's. These are the things in any patient who has an arrhythmia, not just cardiac arrest, that you should be always kind of in your head, hey, does my patient have any of these factors? So that same patient in our scenario, right? You go and get some vitals and you talk to the patient. Patient's saying, oh, doc, I've got chest pain and I'm feeling kind of sweaty. The patient's clammy on exam, and you get a set of vitals, and the vitals are, heart rate of 142. So this is, back when the patient was normal, and the bottom, this is their new rhythm. So their heart rate's 142, their blood pressure is 86/51. They're satting 94% on 2 liters of nasal cannula. So obviously this patient is, if they're not already in extremis, they're basically there, they're in shock, and they're tachycardic. So this is just a very quick refresher. You guys should really check out this website, Life in the Fast Lane. It's a great emergency and critical care website, but fantastic reference to look up really anything in terms of these kind of acute care issues. So reading an EKG, the fundamental basics of it, right? Your QRS complex is here, and there's a fundamental difference that I'll go into in a little bit, but you really should be able to measure the width of the QRS complex in terms of seconds. Each box here, each box consists of 0.02 seconds. So what that means is a very quick way to measure, 0.04 seconds. So a quick way to measure someone's heart rate is to say, okay, well, if each QRS complex is 1 large box away or 5 small boxes away, that means their heart rate is 300. If it's 2 big boxes away or 10 small boxes apart from each other, then their heart rate's 150. So it kind of gives you like a very quick way to measure someone's heart rate on the EKG. So like I mentioned, if someone is in a fast abnormal rhythm, the first differentiation that you're going to make is it a narrow QRS complex or is it a wide QRS complex? And that fundamentally differentiates your management pattern for these 2 arrhythmias. So a narrow QRS is one that is less than 0.12 seconds in width, and a wide QRS is one, of course, that's above that. Narrow complex arrhythmias typically originate above or within the AV node, whereas wide complex tachyarrhythmias originate within the ventricle itself. And kind of that weird conduction through the ventricle gives the QRS that wide appearance. So let's say, you take a look at this patient's rhythm strip, and you notice that they are in a tachyarrhythmia, they're tachycardic, and their QRS complex is narrow. So now your second kind of decision point in terms of management is going to be this: is the patient stable or are they unstable? And again, by unstable, I mean they're hypotensive. They're essentially showing evidence of end organ hypoperfusion, right? So hypotension is probably the quickest way to elucidate this, but also changes in the EKG or ischemic changes in the EKG, I should say. Chest pain, if they're just completely out of it, if they're completely altered, if they've starting to lose consciousness, those things, you drop everything and you say, okay, I am going to give this patient electricity. If they're stable, we can talk about medical management, but for now, we're going to talk about this unstable state. So synchronized cardioversion, you guys have probably heard that term. Really all it means is giving the patient a shock that is synchronized to the QRS complex, okay? When you've decided you need to do this for a patient, you need to prepare a few things, right? So you need to put them on monitoring, make sure that they are on tele, O2, end tidal, their blood pressure is monitored. You want to get IV access because you need to probably give sedation medication to these patients and get the code cart ready. So sedation medication, you guys know procedural sedation very well as an IR. So you're giving typically Versed and fentanyl, some combination of that. You want to have supplemental O2 when they're hypoxemic. However, very important to note that when you're delivering the electricity to this patient, it is potential hazard. It can light on fire, essentially. So you want to turn off the supplemental O2, or if you're certainly having a face mask or blow-by oxygen, you want to turn that off before you shock the patient. And then, of course, you want to have your defibrillation equipment ready. So that consists of pads and the actual defibrillation box. So what are the principles for applying these electrodes? There's just a couple things you should keep in mind. Number one, maximize the pad contact with the skin. So you want to remove excess body hair. You can shave that away. And then excess moisture will also prevent the electricity from really getting down to the heart. So you want to dry off the patient as much as you can. And then, of course, remove all dangerous material from the field. So air gaps can cause arcing of electricity and can cause fires, supplemental O2, like I just mentioned, and then any sort of jewelry as well that can conduct electricity. As far as electrode placement goes, there's really two ways to do this. You can either do the anterolateral approach or the anteroposterior approach. There have been some studies that have shown somewhat better conduction anteroposterior. However, I will say that if you're in a position and the patient is about to lose consciousness, or they're hypotensive and just not doing well, in most cases, this anterolateral approach is going to be your quickest thing. You don't have to turn the patient. You just put the pads on, in the right parasternal location, and then lateral chest wall. And that'll be enough to get that electricity through the atrium and the ventricles if needed. How do you deliver electricity? So really it's two things, right? You're turning on your defibrillator box, your Zoll box, and you're going into synchronized mode, and that's a button that you push. And you can see the little carrots on top of the rhythm strip. And what that tells you is that the box will only give electricity on the R wave. And that's important because you do not want to deliver electricity on a T wave, because that can cause a somewhat stable superficial or supraventricular tachycardia to degenerate into ventricular tachycardia or VFib. So always synchronize when you can. Additionally, most newer defibrillators are biphasic in terms of their delivery pattern. That's basically letter B here is biphasic, meaning it delivers the electricity in two different directions. And that's been shown to be more effective than just a monophasic delivery. Typically, you don't have to worry about switching modes. The newer ones are always biphasic. And then energy-wise, typically you're starting around the 100 to 120 mark and then going up to 200 joules. If you don't know what to do, just go to 200 joules. That's a safe place, safe amount of electricity to deliver while being effective in most cases. So back to our scenario, in this case, you've given the electricity, you've shocked them out of their state, but let's say that the patient is a little bit more stable, but tachycardic, right? So their blood pressure is 114/63. They're on 2 liters nasal cannula, and they're telling you, oh, I've got some chest discomfort, some palpitations, some weird feeling in my chest, but I'm doing okay. It's just kind of weird, whatever's happening to me. So now we're going down this narrow complex tachycardia, stable but symptomatic path. And that's when you can really start taking your time. And honestly, that's where a lot of your patients in the IR setting will be. They won't necessarily be crashing, but they'll be, all of a sudden become tachycardic. So you can talk about medical management. Step number 1 here is, because you have a little bit more time, right? You're not shocking the patient immediately. You can really think about identifying and treating reversible etiologies, right? So back to those things that I was talking about at first, take your time, always think about these things. Think about, can I change any of these factors? Can I give the patient potassium? Can I diurese them? Are they underfilled? Should I give them fluid? Always be thinking about these things. So steps number 2 and 3 are identifying your underlying rhythm, utilizing vagal maneuvers or adenosine to both diagnose and treat these rhythms. And then after that, rhythm-specific pharmacologic management. So now when we're talking about, stable narrow complex tachycardias, all NCTs can be split further into regular rhythms or irregular rhythms, or, you're uncertain whether the rhythm is actually regular or not. So when we're talking about regular narrow complex tachycardias, we're talking about, these are the 5 main groups. So you've all kind of heard of paroxysmal SVT. So this bucket consists of your AVRT, your AVNRT. These are reentrant atrioventricular or AV nodal circuits, right? So AVRT is atrioventricular reentrant circuit, and AVNRT is where the circuit is limited to the AV node itself. In this case, you're typically not going to see normal P waves. What you will see sometimes is like these weird retrograde P waves. You might see a P wave hidden inside the QRS complex. But what you'll see is very fast rhythm. You'll see big QRS complexes that are tall, but you won't necessarily see P waves. Then you have something called automatic junctional tachycardia. So that is increased automaticity in the AV node itself. So that's not a reentrant circuit. It's just the AV node itself picking up speed. And here you'll frequently see retrograde P waves. So that's because the AV node is firing and the electricity is going down to the ventricle, but it's also going up to the atrium in the opposite direction. And so you'll see this kind of a P wave that's backwards or upside down. Then you have atrial flutter at a regular conduction rate. And so that is a re-entry atrial circuit. You can have variable conduction. So here you're having a 2-to-1 conduction where one of the P waves is conducting and the other P wave is not conducting. So only one of the P waves is associated with the QRS complex. But if you have irregular or variable conduction, the QRS complexes can also be irregular. And here you have the characteristic sawtooth P waves, right? So these are the P waves. They look like, they're sawtooth pattern. Then you have atrial tachycardia. So this is an ectopic atrial pacemaker. So separate from the AV node that's firing faster than the AV node by itself. And so that ectopic pacemaker is then carrying down to the AV node and causing the ventricle to go as well. So you have a single abnormal P wave. You can see it kind of buried right there and right there. And it's a regular rhythm because that single abnormal focus is conducting down into the AV node and causing the ventricle to fire. And then, of course, don't forget about sinus tachycardia. So sinus tach obviously has P waves, but in and of itself, it's not an abnormal rhythm. It's just indicative of an underlying abnormal condition. Okay, so always remember that. So those are your regular NCTs. Then you have your irregular NCTs. Really, there's two big ones. There's AFib, which everyone knows. And AFib by itself is not a tachyarrhythmia. It only becomes a tachyarrhythmia when there's a rapid ventricular response associated with it. So AFib with RVR is kind of the traditional term. That's an atrial reentrant rhythm. And with this, there are no P waves seen. And so that's kind of your tip-off. And then you have your other irregular rhythm, which is multifocal atrial tachycardia. So if you remember before in the regular rhythms, you had atrial tachycardia or automatic junctional tachycardia. But here, this is also an ectopic atrial pacemaker. But here, there's multiple ectopic atrial pacemakers, and therefore you have multiple different abnormal P wave morphologies. So here's one right there, and then here's another one right here, and then here's another one right here. So there's 3 different P wave morphologies here. Typically, it'll be an irregular QRS rhythm, and that's MAT. So let's say you have a regular narrow complex tachycardia, or you're just not sure, is it regular or irregular? What do? Your first step is going to be using vagal maneuvers and adenosine. And the purpose of that is to slow down the conduction through the AV node. And that helps you uncover or either uncover the underlying rhythm, or if it's paroxysmal SVT or some sort of reentrant circuit, it will actually go ahead and terminate that reentrant circuit and bring back sinus conduction. So sinus node to AV node. So vagal maneuvers are the easiest thing to do, right? So you can either have someone bear down like they're having a bowel movement, or do a carotid sinus massage. So you massage the carotid body. Obviously, don't do this if the patient is at risk of having a stroke. If you know that they have a ton of loose calcification in their carotids, don't mess around with that. But I will say in my career, I've probably had Valsalva work like 1/3 of the times that I've had someone just flip into spontaneous SVT. It's really cool, and very impressive when you can have someone flip out of that rhythm just by bearing down. So always try that first. If that doesn't work, then you can move on to this other really fun drug called adenosine. So this is a IV push. It's extremely quick onset and short duration of action. And what it does is it essentially puts the patient into cardiac arrest for a few seconds. I mean, it's like terrifying, but very cool as well. So it stops the AV node. and then it wears off, and you're hoping that the patient's spontaneous conduction will pick back up after terminating the reentrant circuit. So the initial dose of this is a rapid 6 milligram peripheral IV push, and then you chase it with a saline push, and you're chasing it very fast, right? So you're just slamming this into the patient, basically. If you have a central venous catheter, you can actually still give this through the catheter, just reduce the dose by 50%. So what'll happen is, they're in their SVT, you give this medication and they stop, and you're hoping that when it restarts, it goes to a normal rhythm. If it doesn't do that and they go back into the SVT, which does happen every now and then, you can give second and third doses, boluses of 12 milligrams IV each, to help terminate that. So there are some relative contraindications. If obviously someone has pre-existing AV nodal block, you don't want to cause a complete heart block by giving them adenosine. So be a little careful with that. And then asthma, this can actually set off someone's asthma. So it's not a complete contraindication, but be aware, of that risk. There is extreme caution in this condition called pre-excitation. So in med school, you guys might have heard of Wolff-Parkinson-White syndrome, where basically you have a pre-excited ventricle. And if you have that, it's essentially a accessory circuit. So you can imagine that if you have electrical flow through the accessory circuit and then also through the AV node, if you're shutting off the AV node, you're going to exclusively be going through the accessory circuit, and that can very quickly devolve into ventricular fibrillation. So if someone has Wolff-Parkinson-White syndrome, which shows up as delta waves on the EKG, be very, very careful in giving adenosine. What I will say is that in practice, when someone's heart is going 150 beats per minute, you're not going to sit there and dig into the EKG and be like, oh, do they have pre-excitation? And so for that reason, I actually, if I have time to, I always just put pads on the patient before I give adenosine. That way, if someone degenerates into VFib, I'm there and I'm already ready to shock the patient if I need to. So this is what adenosine looks like. This is a narrow complex tachycardia that the patient is in. And it looks like just paroxysmal SVT because it's regular and there are no real clear P waves in this rhythm. Right here, they've given that push of adenosine. It works extremely fast and they essentially go to flatline. And then after a little kind of jump starting, their sinus node picks back up, right? So you see a real P wave, a sinus P wave right there and right there. And then finally, it starts conducting like it should, and you have P wave, QRS, T wave, P wave, QRS, T wave. So this is what it looks like, and it's really fulfilling and really cool to see when you do it in real life. And you might be thinking, I'm never going to deal with this, but let me tell you, in my first year as an attending, twice I had to give adenosine on the table itself. So very cool and life-saving when you're able to. So, let's say you have a little bit of time to think about this, right? The patient's kind of flipped into NCT, but you don't, they're not unstable. So again, you take your time, you identify the rhythm. They're in sinus tachycardia. All right, great. Look for an underlying etiology, right? Are they volume depleted? Are they volume overloaded? Is their potassium off? Have I given them a medication that's throwing off their rhythm? Whatever it is, uncover the underlying cause. If you think it's paroxysmal SVT, then do like we talked about. You can give vagal maneuvers and adenosine to terminate it. If you're having difficulty controlling the rate, you can give beta blockers and calcium channel blockers to give them a little bit of rate control. And then eventually you can just shock them if you need to. If it's AFib, aflutter, atrial tachycardia, or multifocal atrial tachycardia, so essentially if it's an atrial rhythm, and if they're hemodynamically tenuous, meaning, this is the patient who they're not quite obviously hypotensive, but they're heading that way, or they're starting to develop chest pain and you're just worried about them. And you don't want to drop their blood pressure. You do this all the time. You can give amiodarone, right? So you give a loading dose of amiodarone. You can give 150 milligrams IV, and then you start a drip. So for 6 hours, you can start a drip at 1 mg per minute, and then you can decrease that after 6 hours to half mg per minute. It's a rhythm control agent. And so a lot of times that can pharmacologically cardiovert the patient. You can also give beta blockers, meaning metoprolol or esmolol, or a calcium channel blocker, meaning diltiazem. But just be careful, because these can really cause the patient to become more hypotensive very quickly if they're in one of these atrial rhythms. Always remember with AFib that if the arrhythmia is there for more than 48 hours, you should anticoagulate the patient before you cardiovert them. That's because with these rhythms, they can develop clots in the atrium. And then if you cardiovert them, then these clots can flip off either to the lungs, or if they have a PFO, even worse, to the brain. So you want to be really careful. So I'll say in practice, sinus tach, SVT or paroxysmal SVT, and AFib or A-flutter with a rapid ventricular response. Those are going to be your big three that you'll see. And as you can see, you manage those three very differently. This is just the kind of algorithm tree for narrow complex tachycardia. So you have your stable but symptomatic patient. To manage them, you can split them into regular rhythm or uncertain rhythm or irregular rhythm. If it's regular, then it's either sinus tach, paroxysmal SVT, or A-flutter, or AJT, automatic junctional tachycardia. These are managed very differently. And if it's irregular, then you're really thinking about AFib with RVR or MAT. In those conditions, you're giving amiodarone or rate control if they can handle it from a hemodynamic standpoint. And then always remember, if they're unstable, it's never wrong to cardiovert the patient. All right, great. So same scenario, you're in your pre-op bay and the nurse comes running in. Doc, patient's in a fast rhythm. You go over, do your vitals, and they're kind of unstable, right? And patient's confused and short of breath. And then you see the rhythm monitor and you see the strip. So obviously it's very different than the last few cases. Here, what you notice is that the QRS complex is very wide, right? It's greater than at least 3 boxes here, small boxes. So this is a wide complex tachycardia. With this, yes, you can still, differentiate this into kind of the quote unquote stable but symptomatic or unstable patients. But I will say, wide complex tachycardia is a lot scarier than narrow complex tachycardia, right? We're not talking about, someone flipping into AFib with RVR or flipping into paroxysmal SVT, which can be treated very easily. Here we're talking more about etiologies like monomorphic VTAC, torsade de pointe, or polymorphic VTAC, right? So these are very worrying rhythms, and I will say it is never wrong to shock any patient with a wide complex tachycardia, because they have a high risk of degenerating into an unstable or hemodynamically unstable scenario. So when we're talking about shocking wide complex tachycardia, it's a little bit different than with NCTs, because NCTs are generally, you're able to always detect the QRS complex. And that's important because, like I was talking about, you can do synchronized cardioversion, meaning you're not going to degenerate into a more unstable rhythm if you shock the patient on their T wave or their ST repolarization phase. However, with wide complex tachycardias, particularly with polymorphic wide complex tachycardia, you have all these different QRS complex morphologies, and a lot of times the machine is not going to be able to pick up, what is the QRS complex. It might think, it may just not be able to sync up to one of these complexes. And so in the case of polymorphic VT, like this, really what you're going to be doing is called defibrillation, which is the same exact thing as you would do in someone with pulseless VTAC or pulseless VFib. You're just defibrillating the patient. So that's done at 200 joules. It's obviously, by definition, it's unsynchronized, very easy to do. when someone has, on the other hand, monomorphic ventricular tachycardia, meaning they only have one QRS complex morphology, you can still do synchronized cardioversion. And typically monomorphic VT you can snap someone out of this with less electricity. So you can start at about 100 joules with monomorphic VT. So, we talked about unstable wide complex tachycardia. I put quotations around stable but symptomatic wide complex tachycardia because, again, it's really hard to find someone who is perfectly stable, talking to you, asymptomatic, looking great, who's in this sort of a sine wave morphology, right? I mean, so if you do find someone like that, you can, if you want, separate them into regular and irregular rhythms. Regular wide complex tachycardia, regular WCT can be split into monomorphic VT or SVT with aberrancy or accessory conduction. So basically, monomorphic VT is a rhythm that originates in the ventricle, and it is highly associated with underlying cardiac disease. Whereas SVT with aberrancy is just regular old supraventricular tachycardia that originates above the ventricle or AV node, but that patient also has an either aberrant conduction that slows the conduction down and makes the QRS complex wide, or a second accessory conduction pathway like WPW syndrome or pre-excitation. And that also can widen the QRS complex. Now, I hesitated to even include the slide in this talk because really, when you're talking about this differentiation, it's a little bit academic. There are some criteria to differentiate whether something is monomorphic VT or SVT that's weird or aberrant. But in practice, it's really hard to differentiate these things. Even trained cardiologists have a hard time at it. There are some criteria. If you see fusion beats and if you see AV dissociation, then you're talking more about a intrinsic ventricular rhythm and intrinsic monomorphic VT. But I would not be myself, confident enough to really differentiate these in an emergent scenario. So some people say, if you're totally confident that something is an SVT with aberrancy, sure, you can go ahead and give them adenosine. But you're in that same scenario here where if it's pre-excitation, you give them adenosine, they're going to just destabilize and degenerate into ventricular fibrillation, and you're going to have to shock them anyways. So unless you're completely confident that this is SVT, I would probably stay away from adenosine. And any regular wide complex tachycardia, I would just treat like monomorphic VT. It is never, again, I'm going to pound this in, it is never wrong to shock wide complex tachycardia. All right, if you are in a situation where it's monomorphic VT, they're pretty stable, and you don't want to shock them, you can go ahead and give them some amiodarone. And if that doesn't work, you can give them lidocaine or procainamide or sotalol. These are all anti-arrhythmic or rhythm control agents, right? So, when we talk about our classic arrhythmia pharmacologic agents, they're typically split into rate control and rhythm control. So, for example, beta blockers, calcium channel blockers are rate control agents, but amiodarone and lidocaine, procainamide, sotalol, those are all rhythm control agents. So if someone's in monomorphic VT, you could try giving them a rhythm control agent. All right, let's say you have irregular wide complex tachycardia. So that is almost by definition, that's something called polymorphic ventricular tachycardia. In the setting of someone who has a known prolonged QTC, polymorphic VT is called torsade des pointes, right? So you learn that, on step one, it's French for twisting of the points, but that is this classic rhythm where, you have all these different QRS complexes. They can be really tall at first, and then they kind of narrow down, and then they get bigger again. And that is associated with a prolonged QTC. So if you run into that situation, always remember in the back of your head, give these patients mag sulfate. That doesn't mean that you're going to only give them mag sulfate, right? You can still shock these patients. You still should probably shock these patients, but just remember that this is caused by prolonged QTC. You can correct the QTC interval by giving them some mag sulfate, 1 to 2 grams IV over the course of 15 minutes. And also identify other agents that are prolonging the QT interval. If you know that previously the patient had a normal QT interval and then they all of a sudden develop polymorphic VT, that should really tip you off that, hey, this patient may have active myocardial ischemia going on, because this kind of a scenario is highly associated with that. So this is a point where, you notice nowhere here did I say, just take a step back and call cardiology, because I firmly believe we should be able to manage emergent arrhythmias. But if someone goes into polymorphic VT and they had a normal QT, all of a sudden, this is somewhere where I'm immediately paging cardiology, because they may have active coronary ischemia going on. The textbooks say give them adenosine or a rate control agent. Really what I'm doing is I'm shocking this patient and I'm calling cardiology right away. All right. So the last thing that I'll get into here is really just talking about these agents, right? So it's a very dry topic, but honestly, if you memorize this table and go into practice as an IR, I guarantee you're going to save a couple lives throughout the course of your first year as an attending. I know myself, I'll give you a scenario. I mean, I had a patient who came to my table for a venous revascularization, and she was intubated. She had SVC syndrome. She was intubated, and she came down to me, and she was not very synchronous on the ventilator. They didn't sedate her well enough. So she's on my table. She's not really synchronous. Next thing I know, she starts desatting. And she starts desatting, and I can't get her more synchronous. We can't give her enough meds to make her synchronous. And all of a sudden, because she's desatting, she's becoming hypoxic. And because she's becoming hypoxic, all of a sudden she flips into AFib with RVR. And so now I'm really thinking, going down the road of like, okay, well, she's in AFib with RVR, but she's stable. Do I have time to think about this? Do I have time to give her medications? And so I'm already thinking, okay, let me give her something, right? And at that time, she was relatively stable. I gave her metoprolol because that was easiest available in the IR suite. Not only did the metoprolol not work well, but it also made her hypotensive, right? And so now I'm on this place where she's hypotensive. She's in AFib with RVR, so she's unstable. And I immediately get pads on her, and I try pharmacologic therapy one more time, right? So then I go to my amiodarone because she's hypotensive. The amiodarone, I give her a 150 milligram bolus, and it doesn't really work. And by this time, she's still hypotensive. So then immediately I'm like, okay, I need to shock her. And so I already have my pads on her. I do synchronized cardioversion, and all it takes is one shock, and she immediately flips back into a normal sinus rhythm. And by that time, respiratory therapy is already in our room, and we're snowing her at this point, getting her sedated and adequately synchronous with the ventilator. Her SATs start going up, and she never flips back into AFib with RVR. Go ahead and do the case, no problem, right? But if you didn't know this algorithm, if you didn't know these medications off the top of your head, I can see how that kind of scenario would be very challenging. You might have to call a code team. The code team takes 5 minutes to get to you. And by that time, you're already doing compressions. And that's not where you want to be. So take your time. We're going to be sending out, Sejal and Austin and the whole team have been really kind to start putting together a cheat sheet for you guys to really be able to refer to. And things like this hopefully will be on the cheat sheet. But just to go over it really quick, right? So you have your rate control agents, which are your beta blockers here. Really, you need to know 2 beta blockers, right? You have metoprolol, which is an IV push. It's a great medication, easily available at most hospitals. And then you have esmolol, which is a drip. That's also a great med, but a lot of places, might not feel comfortable starting esmolol, or it may not be readily available. The nice thing about esmolol is that it's extremely quick off, extremely quick on. And so very easily titratable. You start with a 500 mic per kg bolus, and then you just infuse it. Whereas metoprolol, you give 5 milligram boluses, essentially as much as you need to. The thing with the beta blockers that you got to watch out for is that, like I said in my scenario, it can worsen your hypotension. You want to avoid it in decompensated heart failure, or if they already have a pre-existing AV block, because of course you can put them in a complete heart block. And then if they have reactive airways disease, watch out for their SATs with these meds. If you don't like using metope or esmolol, you can do a calcium channel blocker. That works in a similar mechanism by slowing the AV node. With DILT, DILT's kind of my go-to. I give 0.25 mg per kg and then start an infusion. DILT is an infusion. Very similar kind of cautions with that, right? So it can make your hypotension worse. Always keep that in mind. Verapamil is a similar agent that is an IV push as opposed to an infusion. And then you get to amiodarone. I love amiodarone. It's easily available again. You have less risk of hypotension. That's why in my ICU patients, this is actually the go-to drug if someone flips into AFib with RVR. It can prolong your QT, and in extremely rare cases, it has caused torsades, but very rarely. And of course, it can cause hepato and pulmonary toxicity. And so watch out for those things if they already have them. DIG, I threw this on there. It's not an acute agent, but if you have nothing else to go to, think about digoxin. Procainamide and sotalol, they are on the, I only put them on here because they're actually on the ACLS protocol for all providers. And so do you use this often? I can't say that I have, but they fall into that antiarrhythmic category with lidocaine, where if someone is in VT that's stable, and they're just chilling, and you can give them these agents, so you can start them on procainamide or sotalol. But if you feel uncomfortable with them, I wouldn't fault you for getting some sort of a consult before starting these agents. So your go-tos are really going to be metope, esmolol, DILT, and amiodarone. Just know those drugs really well, and you will be able to save lives. I guarantee that. So that was my quick overview of tachyarrhythmia for the VIR. Thank you guys for listening. Thank you for watching this in the recorded form. I'm very open to any sort of input or questions. I love working with you guys. And really, my hope is to make acute care an integral, default part of the IR curriculum. It really shouldn't be that surgeons are learning this stuff and we're not. And so anything, any input or questions that you guys have, please let me know. And at this point, I'll take questions.